Hey future nurses, welcome back to the channel where we make Nclex prep simple and stress-free. In today's video, we're diving into one of the most high-yield topics on the Nclex, fluid and electrolytes. From sodium imbalances to potassium corrections, these questions will sharpen your critical thinking and test-taking skills. Grab your notebook, stay focused, and let's master this together, one question at a time. Let's get started. 1. A client presents with muscle cramps, tetany, and a positive Chvostek's sign. Which electrolyte imbalance is most likely responsible for these findings? A. Hyperkalemia, B. Hypocalcemia, C. Hypermagnesemia, D. Hyponatremia. Answer: B. Hypocalcemia. Rationale: hypocalcemia causes increased neuromuscular excitability, which can manifest as muscle cramps, tetany, and a positive Chvostek's sign, facial muscle twitching when tapping the facial nerve. Hyperkalemia primarily affects cardiac rhythm. Hypermagnesemia typically causes decreased deep tendon reflexes. Hyponatremia is more associated with neurological symptoms like confusion or seizures, rather than tetany. Strategy: look for clues of neuromuscular irritability, e.g. tetany, Chvostek's, Trousseau's signs, to quickly rule in hypocalcemia. Remember the common signs linked with calcium deficiency and eliminate options with less relevance. 2. A patient with congestive heart failure is receiving furosemide therapy. Which electrolyte should the nurse monitor most closely? A. Sodium, B. Potassium, C. Chloride, D. Calcium. Answer: B. Potassium. Rationale: furosemide is a loop diuretic that causes significant potassium loss through the kidneys, potentially leading to hypokalemia, which can result in muscle weakness and cardiac arrhythmias. Although it can affect sodium and calcium to a lesser degree, potassium loss is more critical and urgent in clinical management. Strategy: when you see loop diuretics, immediately think of potassium depletion. Apply pharmacology knowledge to anticipate side effects of medications. 3. A patient with renal failure is at greatest risk for developing which electrolyte imbalance? A. Hypokalemia, B. Hyperkalemia, C. Hyponatremia, D. Hypocalcemia. Answer: B. Hyperkalemia. Rationale: in renal failure, the kidneys lose the ability to excrete potassium, leading to accumulation and resulting in hyperkalemia. This is a dangerous condition due to its potential to cause fatal cardiac dysrhythmias. While hypocalcemia and hyponatremia may also occur, hyperkalemia is the most acute and life-threatening imbalance. Strategy: match organ function with electrolyte regulation. Know that impaired renal excretion leads to electrolyte buildup, especially potassium. 4. A patient with severe vomiting for 3 days is at risk for developing which acid-base imbalance? A. Metabolic acidosis, B. Respiratory acidosis, C. Respiratory alkalosis, D. Metabolic alkalosis. Answer: D. Metabolic alkalosis. Rationale: vomiting leads to the loss of gastric hydrochloric acid, resulting in an increase in blood bicarbonate, which causes metabolic alkalosis. Metabolic acidosis typically results from diarrhea or renal failure. Respiratory imbalances involve alterations in carbon dioxide levels. Strategy: associate fluid loss location with acid-base changes. Loss from the upper GI, vomiting, equals alkalosis. Loss from lower GI, diarrhea, equals acidosis. 5. A nurse is assessing a client with fluid volume overload. Which finding would the nurse expect? A. Weak, thready pulse, B. Hypotension, C. Crackles in the lungs, D. Increased hematocrit. Answer: C. Crackles in the lungs. Rationale: fluid volume overload leads to pulmonary congestion and crackles due to excess fluid in the alveoli. Hemodilution lowers hematocrit. A bounding pulse and hypertension are also expected, not a thready pulse or low blood pressure. Strategy: understand how fluid excess affects circulation and organ systems. Prioritize pulmonary signs for overload due to their potential for rapid deterioration. 6. A patient is admitted with a serum sodium level of 118 milliequivalents per liter. Which nursing action is the priority? A. Encourage increased oral fluid intake. B. Administer 0.9% normal saline IV. C. Monitor for signs of hypernatremia. D. Place the patient on seizure precautions. Answer: D. Place the patient on seizure precautions. Rationale: a serum sodium level below 120 milliequivalents per liter is considered severe hyponatremia and can lead to cerebral edema and seizures. While correcting sodium levels is important, the immediate risk to patient safety, seizures, takes priority. Administering saline may be done concurrently, but seizure precautions are the most urgent initial step. Strategy: prioritize patient safety. When sodium is critically low, always assess for neurological symptoms and take immediate protective actions such as seizure precautions. 7. Which finding would indicate that a patient receiving intravenous fluids is developing fluid volume excess? A. Weight loss of 1 kilogram in 24 hours. B. Decrease in blood pressure. C. Neck vein distension. D. Flat neck veins when supine. Answer: C. Neck vein distension. Rationale: neck vein distension is a classic sign of fluid volume excess due to increased intravascular pressure. A 1 kilogram weight loss indicates fluid loss. Decreased blood pressure and flat neck veins are signs of hypovolemia. Strategy: correlate physical assessment findings with fluid status. Signs of overload include neck vein distension, bounding pulses, edema, and pulmonary symptoms. 8. A nurse is caring for a patient with a serum potassium level of 6.2 milliequivalents per liter. What is the most critical assessment the nurse should perform? A. Assess bowel sounds. B. Monitor urine output. C. Assess cardiac rhythm. D. Check for muscle spasms. Answer: C. Assess cardiac rhythm. Rationale: a potassium level above 5.0 milliequivalents per liter is hyperkalemia, which can cause dangerous cardiac dysrhythmias. Monitoring cardiac rhythm with telemetry, or ECG, is critical. Although muscle symptoms and urine output are important, cardiac complications can be rapidly fatal. Strategy: always prioritize cardiac monitoring in hyperkalemia. Know which electrolyte imbalances are cardiac emergencies. 9. A patient with a history of alcoholism is admitted with confusion and a magnesium level of 1.1 milligrams per deciliter. Which intervention should the nurse anticipate? A. Administer oral potassium. B. Prepare for calcium gluconate IV. C. Administer magnesium sulfate IV. D. Encourage high calcium diet. Answer: C. Administer magnesium sulfate IV. Rationale: hypomagnesemia is common in chronic alcoholics and can cause neuromuscular irritability and confusion. Magnesium sulfate is the treatment of choice. Potassium and calcium may also be low, but magnesium correction takes priority due to its role in stabilizing neuromuscular and cardiac function. Strategy: recognize common electrolyte deficiencies in high-risk populations. Alcoholism strongly correlates with magnesium loss. 10. A client with diabetic ketoacidosis, DKA, is being treated with insulin. Which electrolyte imbalance should the nurse monitor closely during treatment? A. Hypercalcemia. B. Hypernatremia. C. Hypokalemia. D. Hypermagnesemia. Answer: C. Hypokalemia. Rationale: as insulin is administered, it drives potassium into the cells, potentially causing a dangerous drop in serum potassium levels. Although patients with DKA may present with hyperkalemia initially, this shifts rapidly with insulin therapy. Strategy: link insulin administration with potassium movement. Monitor potassium levels aggressively during treatment for diabetic ketoacidosis to prevent life-threatening hypokalemia. 11th. A patient receiving total parenteral nutrition, TPN, suddenly develops confusion and irritability. Which electrolyte imbalance should the nurse suspect? A. Hyperphosphatemia. B. Hypomagnesemia. C. Hypocalcemia. D. Hyponatremia. Answer: D. Hyponatremia. Rationale: TPN can cause fluid shifts and electrolyte imbalances, including dilutional hyponatremia, especially if the solution is hypotonic or if the patient has concurrent fluid overload. Hyponatremia presents with neurological symptoms such as confusion and irritability. Strategy: when assessing altered mental status, always consider sodium imbalances first. Neurological changes are hallmark signs of hyponatremia. 12th, a nurse notes that a client with hypokalemia has an irregular heartbeat. What is the priority intervention? A. Notify the healthcare provider. B. Recheck the potassium level. C. Increase dietary potassium intake. D. Encourage fluid intake. Answer: A. Notify the healthcare provider. Rationale: an irregular heartbeat in a hypokalemic patient is a potential life-threatening arrhythmia. Immediate provider notification is essential, so appropriate interventions, such as IV potassium replacement or ECG monitoring, can be initiated. Strategy: prioritize abnormal cardiac findings. If there's any sign of arrhythmia in the context of electrolyte disturbance, escalate care immediately. 13. Which laboratory value is most concerning in a patient taking spironolactone? A. Sodium 137 milliequivalents per liter. B. Potassium 5.9 milliequivalents per liter. C. Chloride 101 milliequivalents per liter. D. Magnesium 1.8 milligrams per deciliter. Answer: B. Potassium 5.9 milliequivalents per liter. Rationale: spironolactone is a potassium-sparing diuretic. A potassium level of 5.9 milliequivalents per liter is elevated and places the patient at risk for cardiac arrhythmias. This requires urgent intervention. The other lab values are within normal limits. Strategy: know the side effects of potassium-sparing diuretics. Always associate spironolactone with the risk of hyperkalemia. 14. A patient with a nasogastric NG tube on continuous suction is at risk for which electrolyte imbalance? A. Hypokalemia. B. Hypernatremia. C. Hypermagnesemia. D. Hyperchloremia. Answer: A. Hypokalemia. Rationale: NG suction causes loss of gastric contents, which are rich in potassium and hydrogen ions. This can lead to hypokalemia and metabolic alkalosis. Hypernatremia and hyperchloremia are not common in this scenario. Strategy: identify sources of electrolyte loss. NG suction equals loss of gastric contents equals risk for hypokalemia and alkalosis. 15. Which dietary choice is best for a client with a serum sodium level of 130 milliequivalents per liter? A. Low sodium soup and steamed vegetables. B. Watermelon and a sports drink. C. Chicken broth and salted crackers. D. Fresh fruit and low sodium yogurt. Answer: C. Chicken broth and salted crackers. Rationale: a sodium level of 130 milliequivalents per liter indicates mild hyponatremia. Foods high in sodium like chicken broth and salted crackers help increase sodium levels. The other choices are low in sodium and not therapeutic for this condition. Strategy: associate dietary choices with lab abnormalities. For hyponatremia, encourage high-sodium foods when appropriate and not contraindicated. 16. A nurse is caring for a patient with hypocalcemia. Which of the following interventions should the nurse anticipate? A. Administer potassium chloride IV. B. Restrict calcium-rich foods. C. Administer calcium gluconate IV. D. Encourage deep breathing and coughing. Answer: C. Administer calcium gluconate IV. Rationale: calcium gluconate is commonly used to treat symptomatic hypocalcemia, especially when the patient shows signs like tetany or seizures. Potassium chloride is unrelated. Restricting calcium-rich foods would worsen the condition. Deep breathing may be helpful in general care, but does not treat the underlying imbalance. Strategy: match the condition with the antidote or corrective agent. In acute symptomatic hypocalcemia, calcium gluconate is the emergency treatment. 17. A nurse is teaching a patient with a potassium level of 3.0 milliequivalents per liter about dietary sources of potassium. Which food should the nurse recommend? A. Apples. B. White rice. C. Bananas. D. Lettuce. Answer: C. Bananas. Rationale: Bananas are one of the richest natural sources of potassium and are commonly recommended for patients with hypokalemia. Apples, rice, and lettuce contain minimal potassium and are not sufficient for replenishment. Strategy: remember the potassium-rich foods: bananas, oranges, spinach, potatoes, avocados, and tomatoes. Use these in patient education for hypokalemia. 18. A nurse receives a lab result indicating a serum magnesium level of 0.9 milligrams per deciliter. Which assessment finding is most consistent with this lab value? A. Lethargy and hypotension. B. Positive Trousseau's sign. C. Muscle flaccidity. D. Respiratory depression. Answer: B. Positive Trousseau's sign. Rationale: a magnesium level below 1.3 milligrams per deciliter indicates hypomagnesemia, which can cause increased neuromuscular excitability, similar to hypocalcemia. Trousseau's sign is a classic finding. Lethargy and hypotension are more consistent with hypermagnesemia. Strategy: know the overlapping signs of hypocalcemia and hypomagnesemia. Use neuromuscular clues to identify the likely deficiency. 19. A patient with syndrome of inappropriate antidiuretic hormone, SIADH, is most likely to have which electrolyte disturbance? A. Hypernatremia. B. Hyponatremia. C. Hyperkalemia. D. Hypercalcemia. Answer: B. Hyponatremia. Rationale: SIADH causes water retention without sodium retention, leading to dilutional hyponatremia. This condition is characterized by low serum sodium, low serum osmolality, and concentrated urine. Hypernatremia is the opposite problem. Strategy: know the hallmark of SIADH. Water excess plus sodium dilution equals hyponatremia. Use this to eliminate unrelated options. 20. A nurse is assessing a patient who is confused, has dry mucous membranes, and a serum sodium of 154 milliequivalents per liter. What is the most appropriate nursing diagnosis? A. Risk for fluid volume deficit. B. Deficient knowledge related to sodium intake. C. Excess fluid volume. D. Risk for injury related to hypernatremia. Answer: D. Risk for injury related to hypernatremia. Rationale: a sodium level above 145 milliequivalents per liter indicates hypernatremia, which causes neurological symptoms like confusion, agitation, and even seizures. The most urgent concern is patient safety due to altered mental status. Strategy: prioritize safety in the presence of neurological changes. Always associate hypernatremia with fluid loss and brain cell dehydration. 21st. A client with prolonged diarrhea is at risk for which acid-base and electrolyte imbalance? A. Metabolic alkalosis and hypercalcemia. B. Respiratory acidosis and hypernatremia. C. Metabolic acidosis and hypokalemia. D. Respiratory alkalosis and hyperkalemia. Answer: C. Metabolic acidosis and hypokalemia. Rationale: diarrhea causes loss of bicarbonate from the lower gastrointestinal tract, leading to metabolic acidosis. Prolonged fluid loss also causes potassium depletion, resulting in hypokalemia. The other options are inconsistent with typical effects of diarrhea. Strategy: use pathophysiology to guide reasoning. Remember, vomiting causes alkalosis, diarrhea causes acidosis. Electrolyte loss often follows fluid loss. 22nd. A patient with chronic kidney disease has a serum calcium level of 7.2 milligrams per deciliter. Which symptom is the nurse most likely to observe? A. Decreased deep tendon reflexes. B. Soft tissue calcifications. C. Numbness and tingling around the mouth. D. Warm, flushed skin. Answer: C. Numbness and tingling around the mouth. Rationale: hypocalcemia often causes paresthesia, particularly perioral numbness and tingling. It also leads to muscle cramps and tetany. Decreased reflexes are more common in hypermagnesemia. Warm, flushed skin is associated with hypercalcemia. Strategy: match specific neurological signs to electrolyte imbalances. Perioral tingling equals hypocalcemia. 23. Which electrolyte imbalance is most likely to develop in a patient with uncontrolled diabetes mellitus and a blood glucose of 600 milligrams per deciliter? A. Hyponatremia. B. Hypernatremia. C. Hypocalcemia. D. Hyperkalemia. Answer: A. Hyponatremia. Rationale: severe hyperglycemia causes osmotic diuresis and water shifts from the intracellular to extracellular space, diluting sodium and resulting in dilutional hyponatremia. The primary imbalance is not sodium loss but excess water retention in plasma. Strategy: think of fluid shifts in hyperglycemia. Excess glucose pulls water from cells. Diluting sodium in plasma equals pseudohyponatremia. 24. A nurse is reviewing the lab results of a client receiving hydrochlorothiazide. Which electrolyte should be monitored most closely? A. Potassium. B. Calcium. C. Magnesium. D. Phosphate. Answer: A. Potassium. Rationale: thiazide diuretics promote sodium and water excretion, which can also result in potassium loss. Hypokalemia is a common side effect. Although thiazides may slightly increase calcium, potassium monitoring is the most critical. Strategy: know the class effects of common diuretics. Thiazides equals loss of potassium equals risk for hypokalemia. 25. A patient presents with muscle weakness, fatigue, and an ECG showing flattened T waves. What is the likely electrolyte disturbance? A. Hypernatremia. B. Hypokalemia. C. Hyperkalemia. D. Hypocalcemia. Answer: B. Hypokalemia. Rationale: hypokalemia manifests with muscle weakness, fatigue, and characteristic ECG changes such as flattened T waves and the presence of U waves. Hyperkalemia produces peaked T waves, while calcium imbalances affect muscle tone and excitability differently. Strategy: link ECG changes to electrolyte levels. Flattened T waves equals hypokalemia. Peaked T waves equals hyperkalemia. 26. A client with severe burns covering 40% of total body surface area is admitted. Which electrolyte imbalance is the nurse most concerned about in the early stages of burn injury? A. Hypokalemia. B. Hypernatremia. C. Hyperkalemia. D. Hypocalcemia. Answer: C. Hyperkalemia. Rationale: in the early stages of a burn injury, there is massive cell destruction. As cells are damaged, intracellular potassium is released into the extracellular fluid, leading to hyperkalemia. This is dangerous because of its potential to cause life-threatening cardiac arrhythmias. Later, as fluid resuscitation occurs and potassium is lost via diuresis, hypokalemia may occur. Hypocalcemia may also develop later, but it is not the primary concern during the initial phase. Strategy: understand the phases of trauma and fluid shifts. In the initial phase of burn injury, think cell lysis and potassium release. Always assess cardiac rhythm when potassium is elevated. 27th. A patient with congestive heart failure has been prescribed furosemide and reports muscle cramps and general weakness. Which laboratory result would the nurse expect to find? A. Potassium 2.8 milliequivalents per liter. B. Sodium 148 milliequivalents per liter. C. Calcium 10.2 milligrams per deciliter. D. Magnesium 2.1 milligrams per deciliter. Answer: A. Potassium 2.8 milliequivalents per liter. Rationale: furosemide is a loop diuretic that increases urinary excretion of sodium, chloride, and potassium. A serum potassium level of 2.8 milliequivalents per liter indicates hypokalemia, a common side effect of loop diuretics. Hypokalemia presents with muscle cramps, weakness, and, in severe cases, arrhythmias. The other values are within normal limits and not consistent with the symptoms. Strategy: always connect diuretic use with electrolyte monitoring. Loop diuretics, like furosemide, equals loss of potassium and sodium. Watch for neuromuscular and cardiac symptoms when potassium drops. 28th. A nurse is assessing a patient with prolonged vomiting and observes shallow breathing and confusion. The patient's ABG shows pH 7.48, HCO3 30 milliequivalents per liter, and PaCO2 48 millimeters of mercury. What is the correct interpretation? A. Metabolic acidosis, partially compensated. B. Metabolic alkalosis, partially compensated. C. Respiratory alkalosis, fully compensated. D. Respiratory acidosis, uncompensated. Answer: B. Metabolic alkalosis, partially compensated. Rationale: the elevated pH, alkalosis, increased bicarbonate, HCO3, and slightly elevated PaCO2 indicate metabolic alkalosis with partial respiratory compensation. This is consistent with prolonged vomiting, which causes loss of gastric acid and results in a buildup of bicarbonate. Shallow breathing, hypoventilation, is the body's way of retaining CO2 to compensate for the alkalosis. Strategy: interpret ABG values step by step. Identify the primary abnormality, pH and HCO3, then assess if compensation is occurring via PaCO2. Link ABG changes to clinical scenarios. Vomiting equals loss of acid equals metabolic alkalosis. 29th, a client is receiving an IV infusion of 3% sodium chloride for severe hyponatremia. What is the most important nursing action during this therapy? A. Monitor bowel sounds every shift. B. Assess pupil reaction and size. C. Observe for signs of pulmonary edema. D. Measure daily intake and output. Answer: C. Observe for signs of pulmonary edema. Rationale: 3% sodium chloride is a hypertonic solution and must be administered cautiously. It pulls fluid from the intracellular to the extracellular space, which can rapidly lead to fluid volume overload and pulmonary edema, especially in clients with impaired cardiac or renal function. Signs include dyspnea, crackles, increased respiratory rate, and pink frothy sputum. Monitoring I and O is important, but the priority is respiratory status. Strategy: for hypertonic solutions, always watch for fluid overload. Know that pulmonary symptoms may appear quickly. Frequent respiratory assessments are essential. 30. A patient with a serum calcium level of 6.8 milligrams per deciliter is at risk for which life-threatening complication? A. Intestinal obstruction. B. Cardiac arrhythmias. C. Liver failure. D. Deep vein thrombosis. Answer: B. Cardiac arrhythmias. Rationale: a serum calcium level below 8.5 milligrams per deciliter indicates hypocalcemia, and levels below 7.0 milligrams per deciliter are considered critical. Calcium plays a role in stabilizing cell membranes and is essential for cardiac muscle contraction. Severe hypocalcemia can lead to prolonged QT intervals, arrhythmias, and in some cases, cardiac arrest. Other symptoms may include tetany, laryngospasm, and seizures. Strategy: remember the cardiac connection. For any critical calcium abnormality, think cardiac rhythm monitoring. Review ECG changes associated with electrolyte disturbances. 31. A nurse is caring for a patient with a potassium level of 2.5 milliequivalents per liter. Which of the following is the most concerning assessment finding? A. Generalized muscle weakness. B. Decreased bowel sounds. C. Premature ventricular contractions, PVCs, on ECG. D. Fatigue and malaise. Answer: C. Premature ventricular contractions, PVCs, on ECG. Rationale: although all of the listed symptoms may occur in hypokalemia, PVCs are the most dangerous because they indicate cardiac irritability, which can escalate to lethal dysrhythmias like ventricular tachycardia or fibrillation. Potassium is critical for electrical conduction and muscle function. When levels fall below 3.0 milliequivalents per liter, the heart becomes extremely sensitive. Muscle weakness and GI slowing are expected, but not immediately life-threatening. Strategy: prioritize according to the ABCs: airway, breathing, circulation. ECG changes in hypokalemia are a red flag. Focus on cardiac risks when potassium levels are severely low. 32nd. A client with cirrhosis has ascites and low serum sodium, 129 milliequivalents per liter. Which provider order should the nurse question? A. Fluid restriction to 1,000 milliliters per day. B. Low sodium diet. C. Administer furosemide IV. D. Infuse 0.45% sodium chloride at 100 milliliters per hour. Answer: D. Infuse 0.45% sodium chloride at 100 milliliters per hour. Rationale: 0.45% sodium chloride is a hypotonic solution and would further dilute serum sodium levels, potentially worsening hyponatremia and increasing the risk of cerebral edema. Patients with cirrhosis often experience dilutional hyponatremia due to water retention. Restricting fluids and sodium and using loop diuretics like furosemide are appropriate to manage fluid overload and ascites. Strategy: in hyponatremia, avoid hypotonic fluids, which worsen the condition. Know which IV fluids are hypotonic: 0.45% sodium chloride, D5W, and their indications. 33rd. A nurse is teaching a client who is at risk for calcium oxalate kidney stones. Which dietary instruction is most appropriate? A. Increase intake of spinach and beets. B. Drink 2 to 3 liters of fluid daily. C. Take vitamin C supplements daily. D. Increase intake of animal protein. Answer: B. Drink 2 to 3 liters of fluid daily. Rationale: hydration is key to preventing kidney stones. Increasing fluid intake helps dilute urine, reducing the risk of crystal and stone formation. Spinach and beets are high in oxalate, which should be limited. Vitamin C can increase oxalate production, and high animal protein intake increases urinary calcium and decreases citrate, a stone inhibitor. Strategy: focus on fluid intake for prevention. Use patient education opportunities to discuss limiting oxalates and encouraging a balanced diet. 34th. A patient with Addison's disease is admitted in crisis. Which electrolyte imbalance should the nurse anticipate? A. Hypernatremia and hypokalemia. B. Hypocalcemia and hypermagnesemia. C. Hyponatremia and hyperkalemia. D. Hypernatremia and hyperkalemia. Answer: C. Hyponatremia and hyperkalemia. Rationale: Addison's disease is characterized by adrenal insufficiency, resulting in decreased aldosterone. Aldosterone promotes sodium retention and potassium excretion. Without it, patients lose sodium and retain potassium, causing hyponatremia and hyperkalemia. During an Addisonian crisis, these imbalances can become severe, leading to shock and dysrhythmias. Strategy: know your endocrine disorders and how they affect electrolytes. Aldosterone equals sodium up, potassium down. No aldosterone, the reverse. 35. A patient is receiving intravenous magnesium sulfate for preeclampsia. Which finding requires the nurse to take immediate action? A. Respiratory rate of 10 breaths per minute. B. Absence of deep tendon reflexes. C. Urine output of 25 milliliters per hour. D. Blood pressure of 140 over 90 millimeters of mercury. Answer: A. Respiratory rate of 10 breaths per minute. Rationale: a respiratory rate less than 12 is a sign of magnesium toxicity, which depresses the central nervous system and can lead to respiratory arrest. While absent reflexes and low urine output are also warning signs of toxicity, respiratory depression is the most life-threatening and demands immediate intervention, typically stopping the infusion and administering calcium gluconate as the antidote. Strategy: prioritize ABCs. Airway first. In patients receiving magnesium sulfate, monitor RR, reflexes, and urine output closely. Intervene immediately if any signs of toxicity appear. 36. A nurse is caring for a patient with a serum sodium level of 128 milliequivalents per liter. Which action is most appropriate? A. Encourage fluid intake. B. Administer hypotonic IV fluids. C. Restrict free water intake. D. Prepare for hemodialysis. Correct answer: C. Restrict free water intake. Rationale: a sodium level below 135 milliequivalents per liter indicates hyponatremia. If caused by water excess, the primary treatment is fluid restriction to prevent further dilution of sodium and cerebral edema. Test-taking strategy. Know how to treat dilutional hyponatremia. Eliminate options that worsen the condition, hypotonic fluids or excess water. Dialysis is not first line unless there's renal failure or severe toxicity. 37. Which clinical manifestation is a priority to monitor in a patient with hypokalemia? A. Increased bowel sounds. B. Muscle cramping. C. Shallow respirations. D. Bounding pulses. Correct answer. C. Shallow respirations. Rationale. Hypokalemia weakens skeletal muscles, including respiratory muscles. This can lead to shallow respirations and respiratory compromise. It also increases the risk for cardiac arrhythmias. Test-taking strategy. Prioritize life-threatening complications. While muscle cramps and bowel issues may occur, respiratory depression is an immediate threat to life. 38. The nurse is evaluating a patient for signs of fluid overload. Which finding is most concerning? A. Blood pressure of 118/76 millimeters of mercury. Bilateral crackles in the lungs. C. Flat neck veins. D. Urine output of 60 milliliters per hour. Correct answer. B. Bilateral crackles in the lungs. Rationale. Crackles in the lungs are a hallmark of pulmonary edema due to fluid overload. This condition can impair gas exchange and lead to hypoxia, requiring immediate intervention. Test-taking strategy. Focus on critical complications. Flat neck veins and normal urine output suggest no overload. Lung crackles equals priority concern. 39th. A nurse is teaching a client about foods high in potassium. Which food should be included? A. Apples. B. Carrots. C. Bananas. D. White rice. Correct answer. C. Bananas. Rationale. Bananas are rich in potassium, which is essential for cardiac, neuromuscular, and cellular function. Other potassium-rich foods include oranges, potatoes, spinach, and avocados. Test-taking strategy. Recall commonly tested dietary sources of potassium. Apples and rice are low in potassium. 40. A patient is prescribed a potassium supplement. What instruction should the nurse provide to minimize gastrointestinal irritation? A. Take the supplement on an empty stomach. B. Crush the tablet and mix it in applesauce. C. Take with a full glass of water. D. Administer with an antacid. Correct answer. C. Take with a full glass of water. Rationale. Potassium supplements can irritate the gastric mucosa. Taking them with a full glass of water or with food reduces this risk. Tablets should not be crushed unless specifically directed, as some are extended release. Test-taking strategy. Choose the safest and most effective way to minimize GI upset. Avoid crushing an empty stomach with irritating meds. Question 41. A client presents with confusion, muscle twitching, and a serum sodium level of 122 milliequivalents per liter. Which of the following nursing interventions is most appropriate initially? A. Encourage oral fluid intake. B. Administer hypertonic saline as prescribed. C. Restrict dietary sodium intake. D. Place the client on fluid restriction. Answer. B. Administer hypertonic saline as prescribed. Rationale. The client is exhibiting signs of severe hyponatremia, serum sodium less than 125 milliequivalents per liter, which includes confusion and neuromuscular disturbances. Administering hypertonic saline 3% sodium chloride helps restore serum sodium levels quickly and reduces the risk of cerebral edema. Oral fluids and fluid restrictions may be considered later, but are not sufficient in an acute crisis. Sodium restriction is contraindicated in hyponatremia. Strategy: look for the acute and symptomatic signs, e.g., confusion, twitching. These require urgent and effective interventions. Hypertonic saline is a priority treatment in severe hyponatremia. Question 42. Which of the following signs is an early clinical manifestation of hypocalcemia? A. Bradycardia. B. Constipation. C. Positive Chvostek's sign. D. Polyuria. Answer. C. Positive Chvostek's sign. Rationale. Hypocalcemia causes neuromuscular excitability, and a positive Chvostek's sign, facial twitching when tapping the facial nerve, is a classic sign. Other neuromuscular signs include muscle cramps, tetany, and Trousseau's sign. Bradycardia and constipation are more associated with hypercalcemia. Polyuria is a sign of hypercalcemia or diabetes insipidus, not hypocalcemia. Strategy. When a question asks about electrolyte imbalances, remember the classic clinical signs. Chvostek's and Trousseau's are key in identifying hypocalcemia. Question 43. A nurse is reviewing the ABG results of a patient with a serum potassium level of 6.5 milliequivalents per liter. Which acid-base imbalance would most likely be present? A. Respiratory alkalosis. B. Metabolic acidosis. C. Metabolic alkalosis. D. Respiratory acidosis. Answer. B. Metabolic acidosis. Rationale. Hyperkalemia is commonly associated with metabolic acidosis, as hydrogen ions shift into the cells and potassium ions shift out to maintain acid-base balance. This results in elevated serum potassium. Alkalosis, whether respiratory or metabolic, tends to lower potassium levels due to intracellular shifts. Strategy. Understand ion shifts. In acidosis, potassium moves out of the cells to balance pH, resulting in hyperkalemia. Question 44. A patient with a history of chronic renal failure is admitted for fluid overload. Which of the following nursing diagnoses is the highest priority? A. Risk for electrolyte imbalance. B. Excess fluid volume. C. Activity intolerance. D. Imbalanced nutrition, less than body requirements. Answer. B. Excess fluid volume. Rationale. Patients with chronic renal failure cannot adequately excrete fluids, leading to volume overload, which can progress to pulmonary edema, hypertension, and heart failure. Addressing fluid overload is critical. Although electrolyte imbalance and nutrition are important, they are not immediately life-threatening. Strategy. Prioritize based on ABC, airway, breathing, circulation. Fluid overload affects circulation and breathing, making it the top priority. Question 45. Which food should be avoided in a client receiving spironolactone therapy? A. Apples. B. Bananas. C. White rice. D. Chicken breast. Answer. B. Bananas. Rationale. Spironolactone is a potassium-sparing diuretic, and consuming high-potassium foods like bananas can lead to hyperkalemia, which can be life-threatening. Apples, white rice, and chicken breast have lower potassium content and are generally safe. Strategy. Always pair drug actions with dietary considerations. Potassium sparing equals avoid potassium-rich foods. Question 46. A nurse is monitoring a client receiving IV magnesium sulfate for preeclampsia. Which of the following is the most critical assessment? A. Blood pressure. B. Deep tendon reflexes. C. Heart rate. D. Oxygen saturation. Answer. B. Deep tendon reflexes. Rationale. High levels of magnesium can depress the central nervous system and lead to respiratory depression and cardiac arrest. Loss of deep tendon reflexes, DTRS, is an early sign of magnesium toxicity. While vital signs are important, reflex assessment is more sensitive in identifying early toxicity. Strategy. For magnesium sulfate, remember, check DTRS and respiratory rate frequently. They're early indicators of toxicity. Question 47. A patient's serum phosphate level is 1.5 milligrams per deciliter. Which of the following symptoms is most likely to be present? A. Muscle weakness. B. Tetany. C. Seizures. D. Hypertension. Answer. A. Muscle weakness. Rationale. Hypophosphatemia, phosphate less than 2.5 milligrams per deciliter, can lead to muscle weakness, respiratory failure, and bone pain due to decreased ATP production. Tetany and seizures are more common with hypocalcemia. Hypertension is not a typical sign of low phosphate. Strategy: know the specific manifestations of phosphate disturbances. Hypophosphatemia equals low energy, hence muscle weakness. Question 48. Which electrolyte imbalance is commonly associated with chronic alcohol use disorder? A. Hypercalcemia. B. Hypernatremia. C. Hypomagnesemia. D. Hyperkalemia. Answer: C. Hypomagnesemia. Rationale: chronic alcohol use impairs absorption and increases renal excretion of magnesium, leading to hypomagnesemia. This can cause neuromuscular irritability, seizures, and cardiac arrhythmias. Hypercalcemia and hyperkalemia are not commonly associated with alcohol use. Strategy: for questions involving alcoholism, always consider magnesium and thiamine deficiencies as complications. Question 49. A nurse is caring for a client with heart failure receiving furosemide. Which laboratory value should be monitored most closely? A. Hemoglobin. B. Sodium. C. Calcium. D. Potassium. Answer: D. Potassium. Rationale: furosemide is a loop diuretic that causes potassium loss, predisposing the client to hypokalemia, which can worsen heart failure by causing arrhythmias. Monitoring potassium is crucial. Sodium and calcium may also be affected, but less critically. Strategy: loop diuretics equals loss of K+. Always monitor potassium in these clients. Question 50. Which of the following interventions is a priority in the care of a patient with a sodium level of 160 milliequivalents per liter? A. Administer hypotonic IV fluids slowly. B. Encourage intake of salty foods. C. Place the patient in Trendelenburg position. D. Administer 4 bolus of hypertonic saline. Answer: A. Administer hypotonic IV fluids slowly. Rationale: a serum sodium level of 160 milliequivalents per liter indicates severe hypernatremia, which can cause cellular dehydration and neurological symptoms. Administering hypotonic fluids, like 0.45% normal saline or D5W, helps reduce sodium levels gradually and safely. Rapid correction can cause cerebral edema. Hypertonic saline would worsen the hypernatremia. Strategy: in sodium imbalances, correct slowly. Rapid shifts in serum sodium can lead to life-threatening cerebral edema or demyelination. Let's know how many questions you answered correctly by dropping it in the comment section below. Please subscribe, like, and share. We love you.